Hello, I'm Dr. Richard Krasuski from Duke University Medical Center. I'm joined today by my two esteemed colleagues, Dr. Rajan Sagar from UCLA Medical Center and Dr. Paul Forfia from Temple University Medical Center. Today's discussion is going to be the treatment of the advanced pulmonary arterial hypertension patient. What do we do? So obviously we've had tremendous advances in the field of pulmonary arterial hypertension. We now have many different agents. We have better agents, presumably from the tolerability standpoint, but there are still a group of patients who, despite everything we do, they continue to get sick, or they present to us too late, essentially, to treat them in a non-invasive fashion, and they end up basically really sick, or they end up in the intensive care unit. For the intensive care unit patient, there are precipitants that get them there. There's volume overload. There's management of their hemodynamic state, either inotropes, things that we can do. So just to start, let's take a step back and let's talk a little bit about those patients and how they get to that particular disease state, and is there ways we can even prevent that? So Rajan, I'm going to have you start. Tell us a little bit about the characterization of this particular patient population that ends up in the intensive care unit.
Yeah, so Rich, as you know, it's really important to identify who these patients are, and sometimes they will present to us like that as their opening presentation. And sometimes they're evolving into such a patient over time, despite best medical therapies. These patients are clearly discernible, in my opinion. Not necessarily the ones that are going to evolve, but once they have evolved, there's clear characteristics, both symptomatically as well as objectively with the studies that we do to determine who these patients are. And it kind of goes back to risk stratification. As we know, we try to put these patients into risk categories, low, intermediate, and high risk. And so these high-risk patients, as we're discussing today, really have very characteristic symptoms. They're very limited, often with simple activities. They may or may not be hypoxic, and that may or may not be related to patent foramen ovale. It may actually be related to a very low cardiac output state. They often have, some degree of tachycardia, relatively speaking. They may be relatively hypotensive. And again, when we look at these patients objectively using echocardiography, and Dr. Forfia can speak to that much better than I, as well as their functional capacities, either in the form of a 6-minute walk distance or in a cardiopulmonary exercise test, as well as serologically with brain natriuretic peptide, and hemodynamically when we actually do diagnostic or follow-up right heart catheterizations, with fairly limited cardiac outputs and low mixed venous saturations of oxygen, et cetera. And a lot of these patients, we can identify them very quickly up front based on those tests. As you mentioned, a lot of these patients are volume volume overloaded. We can pick that up pretty easily on the exam. Many of them will actually have ascites in addition to the lower extremity edema. And I think those are some of the clues we use to find these patients.
So Paul, when you get one of these patients and you think they're heading towards the ICU, what type of things do you initially do? How do you decide on what type of invasive monitoring you're going to do, and what your early strategies are going to be? How advanced are you going to? How quickly are you going to move?
Sure. So I just want to underscore first that the advanced PAH patient is the patient who has progressive and persisting symptoms of functional incapacity, clinical right heart failure, cardiac imaging evidence of severe right heart dilatation and dysfunction. Despite our best efforts at therapeutic intensity, escalating their medications, the patient's disease is progressing, and it's all in all of its faculties, despite what we're doing. And so when I hear advanced PAH, it's a safe assumption the patient has evidence of decompensated right-sided heart failure. And those patients almost universally, either presenting to our telemetry floor or to the ICU, are going to be volume overloaded in a state of circulatory decompensation. So intravenous diuretics become a cornerstone part of their therapy. We've got to get their right atrial pressure down, decongest their liver, decongest their renal venous circulation. They often have cardiorenal syndrome due to that very phenomenon. And oftentimes in clinical practice, physicians are hesitant to use intravenous diuretics in a patient with PAH who's in a decompensated state. And it's important that one of the takeaways from this brief discussion is that we must diurese these patients. It's actually been shown in multiple studies that intravenous diuresis is safe and effective in decompensated right heart failure. So I'm going to be looking to get volume off of the patient. I'm going to be trying to escalate their PAH medical therapies, but I'm going to be trying to do it in a way that does not actually cause too much systemic vasodilatation that causes the patient to lose their systemic arterial blood pressure at the same time. So in the sickest of sick patient, we often even have to use pharmacologic support to prop up their systemic vascular resistance while we're continuing to dilate the pulmonary vascular bed, support the right heart, and get the volume off. So,
Do you have preferred agents that you like to use in terms of?
Well, I do, and you know, if a person needs treatment for decompensated right heart failure and PAH, I'm going to use the PAH-specific therapies as my primary modality to offload the right heart and improve RV function. If I need to constrict the pulmonary vascular or the systemic vascular bed, I'd rather do it with a non-inotropic agent. So for example, neosynephrine or vasopressin first. The reason why I say that is because when you start to add on things like epinephrine, norepinephrine, or milrinone or dobutamine, you run the risk of the patient being triggered into an atrial arrhythmia. Once you start getting into atrial arrhythmias in this type of patient, you can really get into a very, very unstable situation quickly. So if the SVR needs to be supported, I'd like to use an SVR-specific agent and avoid the excessive inotropic stimulation.
So these are some really complex ventricular interactions, and one action can obviously lead to a whole slew of other problems. So thank you very much, gentlemen. That was a very astute discussion, and we're going to continue our discussion later on.